So we'll go ahead and get started with the session. Can you all hear me okay? Okay. So our session today is expanding PrEP access through pharmacist-led initiation. We have a great panel of speakers, so I'd like to have each one of them, if they're seated, to stand up and introduce themselves really quickly, where you work, what you do, that type of thing.
Hello, everybody. My name is Dr. Leanna Ramirez. I'm the Chief Clinical Officer at the LGBTQ Center in Las Vegas. We have a sexual health clinic. We recently opened a beautiful, amazing 3-story primary care clinic for complete patient care. We're doing mental health out of there. We're doing some dental, some aesthetics, you name it. We're trying to achieve it. So, pleasure to be here tonight.
Good afternoon, everybody. I'm Fernando and I'm from Raphael Health Center. We're in Federal Qualified Health Center out of Indianapolis, Indiana, where we offer dental, medical, behavioral health, optometry services, and where we also offer a PrEP grant, so the primary care HIV prevention grant. I'm the chief operating officer.
I'm Abigail Taylor. I'm also from Raphael Health Center, and I am our PCVH coordinator, and one of the programs I run is our PrEP program.
Hi, everybody. I'm Grace Lee Parr, she, her pronouns. I'm a legal research manager at NASTAD. Part of my work is I do legal research, obviously, and policy analysis. And as part of that work, I do examine pharmacist scope of practice laws.
Okay. So our objectives today are listed here. So describing how pharmacist-led models can streamline same-day PrEP access in clinical settings, identifying workflow, staffing, and regulatory elements required to operationalize PrEP prescribing through pharmacists, and then applying our lessons learned, and that's why we have our guests here today joining us, applying lessons learned through implementation in diverse clinic settings to design or improve PrEP program delivery. And so the way we have this whole session structured is that we're going to front load a lot of information at the very beginning and then a lot of interaction and discussion, hopefully, toward the end of everything as we have our partners share, and hopefully all of you share as well in your own experiences if you have experience with pharmacist-prescribed PrEP. First of all, how many people in here are pharmacists? So good, we have a good number. How many of you already are prescribing PrEP from your pharmacy or in some way? So we've got a few people that are there anybody, is there anybody here that's looking to implement a program like that of the pharmacist or perhaps in a clinic? I know we're working towards, okay, great. For everyone else, how many people are working at clinics in general? So we have a few people that are, how many people are people from the community that interact with clinics or interact with patients in any way? So we've got a few people that do that as well. Okay, good. I think we have something for everybody in this discussion. So please feel free to jump in at any point if you have any questions though. So I'll start by introducing myself since I'm the first speaker. So my name is Susie Crow. I've been a pharmacist for 20 years. Hard for me to believe that it's been that long, but it has been. I'm also a co-founder of Alchemy, and so I hope everybody enjoyed the Magic Johnson interaction today. But as a co-founder and chief pharmacist for the company, we build in-house clinic-owned pharmacies. And so we do that with a lot of passion towards the true intent of 340B, and in that clinics can use those funds to help build up their programs for patient care. I wanted to talk just a little bit about my own background too. So in the HIV space, I spent 4 years living and working in Kenya, and that's how I actually met our co-founder, Peter Park. And I worked in the space at a clinic at the Empath program. I don't know if anybody's actually heard of the Empath program, but I spent 4 years working there. And if you can imagine, it's a PEPFAR, USAID funded clinic serving about 127,000 patients actually actively on HIV medication. And there's a lot of challenges that go along with managing that many patients. And you can imagine recently with some of the PEPFAR changes and USAID changes, how that's been a big challenge for them in the past couple of months. But that's really my background in the space of HIV. And then, of course, when we founded the company, coming in with that background of HIV experience, also coming in with the goal to take some of the things that we've learned from working in a space like that where there's a lot of challenges with healthcare and actually applying those to what we do in the United States. I wanted to talk just a minute about my own family and my own background, because regardless of whether you have HIV, you have other conditions, there are always healthcare barriers that limit your access to healthcare. And so talking about my own family, I grew up in rural Indiana, actually ironically in a town called French Lick, Indiana, which happens to be the hometown of Larry Bird, and we're partnering with Magic Johnson. So that was a big joke at first when we started partnering with them. But the town has about 1,200 people in it, and it's about 2.5 hours away from healthcare in Indianapolis, about an hour away from healthcare in Louisville. And so my father, who's pictured in the second picture up there, actually, when he was young, had rheumatic fever, acute rheumatic fever. Does everybody know what that is in general? So basically, you get acute rheumatic fever if you have a strep infection and you don't treat it. And so you get acute rheumatic fever, it inflames the heart, you get inflammatory process that affects your heart valves, ultimately leading a lot of times to having to have your heart valves replaced. And so that itself is a sign of limited access to healthcare. And so once later in life, he actually passed away at the age of 67, but later in life when he had to get health care from a cardiologist, his cardiologist was located in Indianapolis, he was uncomfortable driving into the city, and so it was honestly a full day trip for not only him, but someone else just to get him to the health care he needed. So he ended up being managed a lot of times in our small 10-bed rural hospital for conditions, and if he were living in a city, would be managed from probably a cardiac care unit by a cardiologist. So I've experienced my own limitations in healthcare access, and that's one of the reasons why I'm so passionate about this and making sure that all of our patients, and we know with PrEP, our patients consistently experience barriers to healthcare that prevent them from getting the care they need, and HIV as well. And so just wanted to bring that into the picture. And I'll mention just briefly, my sister-in-law's on the right, was diagnosed with Hep C when she was born, was never told about her diagnosis, never got care, developed severe liver disease before she realized what her diagnosis was, and actually passed away from hepatitis C. So yet another driving factor behind my desire to make sure that we're getting care out to patients that need it. So I have we already basically talked about that. I was trying to get a good feel of what different types of people we have in our audience. So when we talk about HIV prevention strategies, our topic today is PrEP, but I don't want that to be the only topic because there are so many other things that go along with prevention for HIV. So making sure your patients have access to clean needles. Those laws, of course, vary state to state, and so knowing what your laws are in your state is really important. Also blood product screening, which is something we often take advantage of happening, but there's still a small chance that you could contract HIV or Hep C from a blood product. Interestingly, if you're looking for partnerships and you're working at a clinic and you're doing mobile testing, or you're doing looking for partnerships for patients, all of those places like plasma centers do Hep C testing, they do HIV testing already. A lot of times they don't direct patients where to go once they've done testing. And so again, that's the potential opportunity to partner with them and reach those patients where they are already getting some form of care or donating plasma. PrEP, of course, condoms, having condoms available to share with patients whenever we're out or prescribing PrEP is important. Also, there's a common misconception: if you start PrEP, you don't need condoms anymore, and so you're still susceptible to getting STDs, sexually transmitted infections, and so it's still important that you counsel your patients about that as well. PEP is another important consideration. So PEP stands for post-exposure prophylaxis. So if someone's exposed to HIV early, and it's early within 72 hours of that exposure, they may actually need PEP instead of PrEP. And so that's a treatment, really an HIV treatment. They go on multiple drugs for 28 days to prevent them from actually contracting HIV from that acute episode. When you're coming up, the reason why I wanted to bring PEP up is PEP is one of those things, if you're building a protocol for PrEP, you're interacting with patients that may actually potentially need PrEP as well. And so having that in consideration when you're building your program, so that you have, so for example, we're building a protocol for our center at Raphael for a collaborative practice agreement, and we're building PrEP into that collaborative practice agreement along with PrEP for that reason, because if you don't, you definitely need to have a plan for how to manage those patients as well. The counseling points, it's not just bring someone in, test them for HIV, start PrEP. There's a lot of counseling points that we need to be sharing with patients. And then also providing regular HIV and STD testing. If they're starting PrEP, they first of all need to know that they have to do that on a regular basis. But if not, and they still have ongoing risk factors, of course, they need to do it as well. And then if you have a patient who has a partner that has HIV, they're of course at high risk of contracting HIV from their partner, but knowing U equals U. Does anybody know U equals U? Anybody want to share what U equals U stands for? Undetectable equals untransmittable. So if your partner has an undetectable viral load, they can't pass HIV on to their partner. And so that's important as well. So if you know that your patient has partners that have HIV, and we know that they're undetectable, they're protected. I wanted to talk a little bit about the incidence of new HIV cases, because again, this is what we're trying to prevent by using PrEP. So there's about 1.3 million new cases of HIV worldwide each year. If you look at the United States, there's about 30-ish thousand, about 32,000, I think was the latest statistic of new cases of HIV in the US. When you look at those numbers, there's disparity in who actually has contracted HIV over the past year. So about 9,000-ish of those are Hispanic and Latino men who have sex with men, followed by African American men who have sex with men, and then white men who have sex with men. And then all of our populations that are heterosexual follow that, those numbers. That's important because our patients that are often getting PrEP may not fit those same demographics. And so again, we may need to go out and find those populations and test those populations, and if they're negative, get them on PrEP. So as you would expect with PrEP and its availability since 2012, there has been a decrease in new HIV cases in the US. And so from 2012 to 2022, there's been a significant increase in the mean PrEP coverage, meaning the number of patients who need to be on PrEP that are actually on PrEP. And so we're about 1 in 4 at this point for people who need PrEP, or 1 in 4 people are on PrEP that need it. There's, however, been a moderate decrease in HIV diagnosis over the same time period from 13 to 10.6. I'm a public health nerd, and so these numbers, I get excited with numbers. But anyway, we have states, of course, that have higher levels of PrEP coverage and have larger declines in HIV diagnosis. So PrEP definitely has a population level impact, but that really depends on, are the people who need PrEP actually getting PrEP, and are the people with the highest risks actually taking it? And so while you see that we have an increase in the mean PrEP coverage, the people that need it the most aren't always the people that are getting it. And so there's a disproportionate amount of, for example, white men who have sex with men who are on PrEP compared to some of the other minority populations. So what is PrEP? So PrEP is a pre-exposure prophylaxis pill that, if it's a pill, can be taken once daily. There are injections where you can take it every 2 months. And then there's now one that was just recently approved in 2025 that you can take it every 6 months as an injection, and it will prevent HIV. If you take these medications as they're directed, so if I'm taking a pill, I need to take it every day. If I actually do that, it's 99% effective at preventing HIV infection. So going along with what I was talking about on the last slide, though, there's about 1.2 million people who actually need to be on PrEP, but most of those people, so 82% of those people who could benefit from PrEP, are actually not taking it. And so that involves us getting out there, interacting with people, either from our community pharmacy counters, from our a variety of different methods, and making sure that we're actually reaching the people who need PrEP the most. When looking at who qualifies for PrEP, of course, anal or vaginal sex in the past 6 months and has an HIV partner or have had a bacterial STI within the past 6 months, or inconsistently uses condoms with partners, or if they're somebody with substance use disorder sharing needles, those are the highest risk patients for contracting HIV and needing PrEP. This is actually from the guidelines, and I think it's important. You have your general population out there that may have some risk factors for contracting HIV. Then you have our high prevalence communities as you work toward the middle of the circle. High prevalence communities or groups, so we talked about Hispanic, Latino, men who have sex with men have a higher risk. And then you have people with actual identified PrEP indications with those high risk behaviors. And then finally, the people that are highest risk are people with partners who have HIV and are not virally suppressed. And so thinking about it overall, and really the guidelines recommend that if somebody's interested in starting PrEP, you actually start PrEP because they may not always be sharing because of stigma what their actual risk factors are for starting PrEP. In terms of options, I'm a pharmacist, so I geek out a little bit on these dosing and everything with medications, but just wanted to talk about the 4 medications that are actually available for PrEP. So we have Truvada, which was approved in 2012 to prevent sexually acquired HIV-1 risk in adults. We have Descovy, which is approved for men who have sex with men and transgender women only. So female patients should not be typically taking Descovy. And then we have Apretude, which was approved for PrEP in 2019, I believe, and is an injection. So patients would take their first dose 1 month, take a second dose following month, and then they're on it for every 2 months following the start of the drug. And then we have Yeztugo, who's the drug that's most recently approved, was approved in June 2025, not even mentioned in the guidelines. Have definitely been seeing this drug show up more and more in our pharmacies, prescriptions for this drug, and so wanted to mention it here as well, but that's a sub-Q injection that a patient can get every 6 months. Looking at our guidelines, again, determining our risk, which we've already talked about, looking at making sure that we have the right conditions met to actually start somebody on oral PrEP, which really is we need to check their renal function, and we need to make sure that they're HIV negative before we start PrEP. Descovy, I believe, is you can take it as long as your renal function is greater than 30, and for Truvada, I believe it's greater than 60. I may have that backwards. I think that's right, 50. Okay. For oral medications, again, for men, transgender women, they can take Descovy. If it's a female patient, generic Truvada is an option for those patients. And then looking at the monitoring that we have to do, so every 3 months we're having the patient come back in, we're checking for HIV with the antigen antibody test, also with an HIV RNA test. We're looking for bacterial STIs because, again, we're not protecting patients through PrEP from STI infections. Also talking to them about adherence, making sure that we're hitting all of those other risk factors, whether it's condoms, clean needles, whatever the patient needs in those settings as well. And then every 6 months, renal function check for patients that are over the age of 50 or have baseline renal issues, and then also checking for sexually transmitted infections. And then every 12 months, we're checking renal function for every patient. For cabotegravir, again, same risk factors. There's not a need to make sure that we have a serum creatinine or a renal function test before we start cabotegravir. So that's the difference between our oral and injectable PrEPs. Your dosing information is listed here, and then we monitor the patient. So after the first month they come in, we check them to see if they HIV antigen antibody or RNA test to make sure they're HIV negative. We're assessing for risk factors, checking for STIs at ongoing appointments as they're getting those injections. As a pharmacist, and we're talking about pharmacist-prescribed PrEP, in some states, pharmacists can actually administer those injections. In other states, they cannot. And so making sure that you know what the laws are in your state around that as well is important, because it can determine your whole workflow and pathway of how you do this. For recommendations for lenacapavir, so the new drug, and I will say that we're seeing a lot of prior authorizations and a lot of prescriptions not going through currently because it's such a new approval for the drug. But again, we're assessing for risk. We're making sure they don't have signs or symptoms of acute HIV. We're checking for HIV and making sure that they don't have any contraindications to the medication. And then we're following up at each of their appointments. Also, you can have some injection site reactions and things like that. So checking in with your patients even a few days after they get that injection to make sure that they don't have any of those types of problems. And then if they happen to get acute symptoms of HIV in the meantime, or have been diagnosed with an STI in the meantime, it's good to go ahead and just check, even though they're not getting their next dose until a few months later possibly, go ahead and check for those things. When looking at disparities, which I started out talking a little bit about disparities, but looking at specifically disparities in PrEP use, there are gender disparities. And so first of all, 91% of PrEP users are actually male. Part of that may be the advertising that you see on TV that predominantly features male individuals on those commercials, but we still have about 20% of new HIV diagnoses happening in women. Many of those are from the Black and African American communities. So again, when we're looking at populations that we want to make sure that we're hitting with our programs, it's important to know that. Also, with race and ethnicity, the majority of PrEP users are actually white males, and the majority of new HIV diagnoses are happening in Black or Hispanic males, and so again, that can be a challenge. Age disparities, so patients that are young, so that age 13 to 24 may still have risk factors for getting HIV, but that's the least likely group to actually be on treatment. Again, it's important, or to be on PrEP. It's important to know your state laws and regulations around that as well, because some states allow for you to test and provide PrEP without your parental approval, and other states don't. And so knowing what those rules are is really important. Other age groups are groups most likely to be on PrEP are the 35 to 44 years, and then the over 65. And then one last disparity I just wanted to mention here is geography. So over half of our new HIV diagnoses are happening in the southern states of the U.S., but only 39% of PrEP users actually live in the South. So the South is a big area where we really need to have more access to PrEP. And community pharmacies, initiated PrEP is one way to help solve some of those problems. Other barriers patients might face, I just came from a session talking about the syndemic of HIV, substance use disorder, and hepatitis C. Those barriers can make it difficult for patients to stay linked into care once we start them on PrEP, or stigma is another thing, lack of insurance, so helping patients, making sure that we're able to help navigate some of these challenges like lack of insurance for patients is important. Health beliefs, we also see a lot of patients that have transportation challenges. If they can't get to the pharmacy to pick up their medication or to get their injection, they're not going to stay consistently on PrEP. And so making sure that we're asking those questions is really important. Lack of knowledge or awareness that someone needs to be on PrEP. And again, going back to the advertisements that we see, oftentimes females may not be aware of their need to be on PrEP because it's consistently marketed more toward the male population, but females can benefit from PrEP as well. And then patients often have competing financial needs. And so if you're working with somebody that's unstably housed, food insecure, making sure that we are aware of those things and we're asking those questions from the pharmacy is important. And so if you're interested in learning more about that, that's something we're actually trying to implement from our community pharmacies for all patients, because if patients aren't taking medications in general, a lot of times it's not that they just don't want to take that medication or something like that. Oftentimes it's I'm choosing between having food to eat, putting food on my table for my family, or paying for my medication. And so us asking those questions up front is really important in order for us to be able to maintain people on PrEP, or even maintain people on HIV care or hepatitis C treatments as well. Coming from small town Indiana, there's definitely a fear about confidentiality, but other patients may fear that as well, that their information, we actually see patients that are afraid to get PrEP prescriptions on their insurance because they're afraid their employers will find out about that as well. I don't know if anybody else has seen that, but definitely fears about confidentiality. And then navigating the healthcare system can be very difficult, especially if you're unhoused, unstably housed. If you think you need PrEP, it may take you a couple of months to get into an appointment, to actually see someone in some areas. And so we need innovative PrEP models that actually overcome some of these barriers. And the community pharmacy or pharmacy prescribed PrEP is definitely one innovative way to do this. So why pharmacists? So pharmacists are our most accessible healthcare provider. When I mentioned that it may take a couple of months to get into an appointment, somebody could walk up and talk to a pharmacist at the pharmacy counter almost at any moment, as long as the pharmacy's open. There's a general trust of pharmacists in the community. With healthcare shortages, shifting some of these care pathways for PrEP can allow prescribers and clinics to focus on their more acute or complex patients to manage. And so shifting some of that work away can free them up to take care of other things. And so I wanted to mention there are a number of states already that have laws allowing for this. So that can happen through prescribing through a CPA or collaborative practice agreement, which Grace Lee will talk about a little more in a few minutes. But it can also be independent prescribing. Some states like, not Nevada, New Mexico, there are independent prescribing laws. And so pharmacists can independently, I don't know if anybody in here is from New Mexico or has any, I don't see anybody raising their hand, but yeah, so pharmacists can independently prescribe, not needed to have a CPA in order to prescribe PrEP in New Mexico. And then also prescribing from the community pharmacy counter. Again, not always allowed in every state, is allowed in some states like Nevada. And there's definitely data out there to support the use of pharmacists to prescribe PrEP, and that it's been a successful endeavor. So it's also important, though, if you're going to start doing PrEP prescribing from a community pharmacy counter, that you take the general workflow of the pharmacy into account. And determining if it's a good fit for your site, you definitely need a private place where you can talk to patients. You need to figure out how it works in the workflow. It's not just a matter of writing a prescription for PrEP and starting somebody on PrEP. You need to be able to have all of these counseling conversations, and it may take 45 minutes in your first encounter. And so how do you manage your pharmacy workflow if you're in a very busy pharmacy? Should definitely be taken into consideration. Just looking at what a same-day PrEP start might look like from a community pharmacy. So we would definitely check a detailed patient history, check our HIV test. Many of our pharmacies or almost all of our pharmacies are located inside a clinic already, so it's very easy to get the labs that we need to get. If you're doing this from an independent pharmacy, you have to consider how you manage getting labs for the patient so that we can confirm they're HIV negative, we can check their renal function before we start oral PrEP, for example. We also want to assess for signs and symptoms of acute HIV. We want to provide PrEP education. I mentioned ordering labs. That can be point of care. There are some point of care tests that you do, but those, even if we're doing it from a mobile clinic like we're doing at Raphael, those require venous lab draws. And so as a pharmacist, I'm not certified as a phlebotomist. And so even if I have a point of care machine, making sure that I have somebody on my team that's able to do point of care or blood draws for point of care. Keeping in mind, of course, that some of these patients have bad veins, potentially IV drug users, and so there can be some challenges definitely with drawing the blood. Also talking about health benefits and other social determinants of health need navigation. I mentioned transportation, food security. All of those problems come up on a consistent basis with patients, and knowing how to navigate those so that patients aren't having to choose between getting food and getting their medication is important. And then also checking their insurance. So again, if we're doing this in the pharmacy, we can run an insurance claim, see if it's paid for by their insurance. So making sure that we're doing that and knowing what their preferred drugs are. And then also we can dispense PrEP from the pharmacy counter at the ideal position would be to dispense it on the same day as the visit. And again, a lot of that depends on what your state laws and regulations are around that. But the closer we get PrEP to starting on the same day that the patient visits, the more likely they are to start PrEP. If we're out testing patients in the community, for example, and we require that they come in for an appointment to get PrEP, chances are they're not going to schedule that appointment or they won't show up for the visit. And so doing the most with the time we have while we have them is really important, whether it's at your pharmacy, mobile unit, or however else you're testing in the community. You will have lab results that come back after you've seen the patient, maybe a day, several days later. So making sure that you have a process in place for how you're checking those labs a couple days later and making sure that again fits in your workflow is important. And then also notifying the patient if any contraindications come up or if we need to do additional lab testing. For mobile outreach, which we'll hear a little bit more about mobile outreach in a little bit, but with a pharmacist prescribed model, prescribing from a mobile unit through a CPA. But basically, if your patient, this is the way it normally works, where you're testing from the community. You may have the patient come in and schedule an appointment. We have the appointment. We actually check their labs. And then 1 to 7 days later, once we get their labs back, we can start PrEP. And so the problem with that is we're having all of these time factors in between that result in patients not actually ever following up or starting PrEP. And so when you're doing it from the mobile unit or from any type of testing that you're doing, the closer, again, that you can get to starting on same-day PrEP, the better. So you may not always be able to completely start. For example, if I don't have a phlebotomist available, I still have to have the patient go and get labs drawn, and so I won't be able to start it the same day that I actually see the patient. But then in that case, as soon as I get those lab results, I'm following up with the patient. It can potentially be a next day PrEP situation rather than a same day PrEP situation. And so trying to get it as close to the time that you test the patient as possible. If we're drawing labs, point of care, there are point of care testing systems like the Piccolo, where you could get renal function within 15 minutes. Not endorsing Piccolo or any other company, it's just one that I've actually used. And so you can do testing and know your renal function, and I can do my HIV test and confirm HIV at the same day that I'm actually seeing a patient. And so I can actually start same day PrEP through collaborative practice agreement from the unit. And then again, I'm always going to have lab results that I may not have the results for on the same day. So again, going back and following up on those. Some important steps to managing a mobile PrEP outreach program, which we'll talk about when we have our guests come up and speak. But basically, it's really important that you're forming those community partnerships and targeting organizations that serve those high-risk populations to begin with, which we talked about at the beginning, what those populations are. It's important to have a PrEP navigator available to help interact with patients, talk to patients, be able to interact with them if they're not showing up for appointments as well is important. Providing those harm reduction items like condoms, providing counseling for patients, and then connecting patients if we need to do so back into the healthcare system, or if you're doing a complete mobile model, connecting them back at a future point for interaction and to receive their medications, receive their next dose of medication if they're getting an injection or something like that. So you can either start a model where a patient receives their first dose from the mobile unit and then gets their second dose in the clinic, or you can start it where you're following up consistently and able to provide those. Also, if we have samples available, providing samples or a prescription for PrEP. Since we have in-house pharmacies, it's potential for us to actually fill the prescription, have pre-filled bottles available, and give those, label those bottles appropriately, of course, when we're dispensing to a patient, but to do that directly from the mobile unit so the patient walks away with the medication in hand, and we can run their insurance claims through the pharmacy system through a laptop with internet access. And then also providing follow-up appointment dates, following up on labs and adjusting if needed, and then ongoing follow-up for patients in case they're lost to follow-up. Here, I just listed a few education points that it's important to cover with patients too. So adherence is essential. If you're not taking PrEP the way that it was intended, there's a greater chance that you can contract HIV. Also looking at risk reduction, side effects of drugs to expect. So for example, with generic Truvada, you can have headache, you can have abdominal pain, at least at the start of the medication. And so making sure patients are aware of that and knowing that also that can subside with time. Also talking to patients about potential interactions with new medications. For example, if you're on generic Truvada and you're taking St. John's wort, those are over-the-counter medications that patients might not typically tell you about, but knowing those types of things and every time a new medication starts so that we could assess for potential interactions. Also, if we're taking an oral PrEP and they're on an NSAID for pain, something like ibuprofen, that can impact your renal function, so minimizing the amount of ibuprofen you take while you're taking PrEP. And then talking to patients about when the medication actually reaches its maximum efficacy. So for example, for males, if you're taking an oral PrEP medication, it may take about 7 days to get to that point where you're getting maximum effectiveness. So just starting PrEP, if you're starting somebody brand new, those first 7 days, they may want to use an alternate method as well, such as condoms. For females, it takes longer, so it may take up to 3 weeks to actually get to that maximum efficacy for the drug. And then what to do, of course, if you miss a dose. And so here are some things to consider if you're thinking about starting your own program are the laws in your state regarding pharmacy-prescribed PrEP, collaborative practice agreements, laws around those, administration of IM injections, completed by the pharmacist, also syringe exchange program laws, because we're in the business of harm reduction along with everything else. Not every state allows you to do those types of things. Having grown up in rural Indiana, not too far actually from the HIV outbreak that happened in 2015, because syringe exchange programs at that time weren't allowed. And so a lot of patients were showing up in a very rural community with both HIV and Hep C infection from sharing needles between family members. And so very important if we have the ability in the states where we're working to include that as part of your program. Also regulations around testing and prescribing PrEP to adolescents. And also pharmacist availability and how it will fit into the workflow. I mentioned that earlier. And then deciding how we're actually going to reach the patients that need PrEP. Again, those patients might not always be walking through your pharmacy door or through your clinic door. And so finding ways that we can reach the patients that are most at risk will be important. And then plans for blood draws, talking about those venous blood draws again, whether we're sending them to a lab, whether we have a phlebotomist available, how we manage that. And then looking at our follow-up labs after appointments, and then providing STI or sexually transmitted infection screening. So basically, PrEP is effective at preventing HIV. Takeaway points for sure. So more effort is needed to get it into the hands of the people who actually need it. And there are a lot of barriers that patients face. So making sure we're not just prescribing PrEP, we're assessing for those barriers as well. And then pharmacists as accessible and trusted health professionals are in the perfect position to actually make that happen. And so I'm excited as we share more as this presentation goes on. I know several of you raised your hands to say you're doing this already, to hear how you're managing some of those challenges from your setting. But with that, I'll pass off to Grace Lee.
All right, I am going to take a little bit of a step back and discuss the legal landscape for pharmacist-initiated PrEP. So as Susie already highlighted and really just the fact that we are all here in this room today signifies that we're acutely aware that there are significant barriers into accessing PrEP. You know, my lived experience is similar to you. I live in rural Virginia. That is an hour drive from a doctor. And that is time and resources that are a privilege that a lot of people simply don't have access to, or at least routine access to. And this is where pharmacists can really come in and address some of those barriers like geographic inaccessibility, because pharmacies offer a much more accessible option for healthcare. You know, 90% of Americans actually live within 5 miles of a pharmacy. You know, they offer extended hours than your traditional primary care providers for certain services and for certain centers. You can receive care without an appointment. And pharmacies can also just serve as that linkage to mainstream healthcare. However, in order for pharmacies to take on that role of initiating PrEP and PEP, their current scope of practice needs to be expanded. Now, there are 5 legal pathways in expanding a pharmacist's scope of practice, and that is a statute, a statewide protocol, a statewide standing order, a standing order from a primary care provider, and collaborative practice agreements. And I'm going to walk through the differences between each of those. So first up is we have a statute, which is, of course, a written law enacted by your state's legislature. Now, a statute might directly grant pharmacists the authority to independently initiate PrEP or PEP, or it might indirectly do so by authorizing the establishment of one of those 4 other legal pathways I mentioned. The next up being a statewide protocol. Now, a statewide protocol, this is when the State Board of Pharmacy establishes guidelines that pharmacists must follow to independently distribute a specified drug. Essentially, what it is it's a blanket prescription with specific guidelines that pharmacists must follow in order to utilize that prescription. Next type of legal pathway is standing orders. Standing orders are also a blanket prescription for a specific drug. This can either be for a specified patient, a patient-specific standing order, or a specified population, a non-patient specific standing order. And standing orders can come in 2 forms, either a statewide standing order or a standing order directly from a primary care provider. So first up is a statewide standing order. This is when a state government official, often the state health director with a doctor of medicine, issues written authorization for a specified drug that any pharmacist licensed to practice in that state may utilize. Of course, because it is statewide, it is non-patient specific. So when we are talking about PrEP or PEP, what that would look like for specified population is individuals at risk of contracting HIV who meet certain criteria would be the eligible population who could utilize that prescription. So the 4th legal pathway and the other type of standing order is standing orders directly from a primary care provider. This is once again a blanket prescription for a specific drug, and this comes directly from a primary care provider, such as a physician. Some states it could be a nurse practitioner. Again, it kind of just depends on the laws in your state. And this might be patient-specific or non-patient specific, but whether it may be non-patient specific, again, has to be authorized by your state's laws. And I'm gonna kind of touch on this more in a moment, but I did just want to highlight the fact that when we are talking about legislation that is specifically targeting pharmacists' authority to initiate PrEP and PEP, it might not enable them to independently do so. It might still require a standing order, so it might still require that collaboration. So the final legal pathway is through collaborative practice agreements. So collaborative practice agreements, essentially this is a contractual relationship between a primary care provider and a pharmacist, where the pharmacist scope of practice is expanded through that collaboration with a primary care provider. Essentially, what happens is a primary care provider delegates some of their patient care services to a pharmacist. Because each of these relationships is unique, each situation requires its own specific collaborative practice agreements. And much like standing orders, they may be patient-specific or non-patient specific, but again, depends on your state's laws. Now, when I mentioned legislation specifically targeting pharmacist authority to independently initiate PrEP and PEP, it is not just as simple as passing this legislation and pharmacists have unfettered authority to prescribe this medication. There's a lot of nuance to this type of legislation, a lot of key considerations that kind of serve as barriers to implementation, truly. And I've kind of just broken down the highlights here. So first up, key consideration in this type of legislation is that of training and education. Oftentimes, this legislation might first require pharmacists to undergo additional training or take additional educational courses before they may utilize any authority granted to them, which, again, just kind of serves as another barrier to pharmacists utilizing that authority. Next key consideration is that of quantity and frequency limitations. Oftentimes, states do not permit pharmacists to prescribe unlimited quantities without a prescription. They put a cap on that. Generally, we're seeing 30 to 90 days supply. So while that's great for getting a person on PrEP, it does not ensure the longevity of that person staying on PrEP. So final key considerations are that of insurance requirements. This includes prior authorization, step therapy, and last but not least is the issue of reimbursement. In my opinion, I would say that the issue of reimbursement is currently the greatest barrier to successful implementation of pharmacist-initiated PrEP. So the reason for this is because pharmacists are not federally defined as providers. Now, the term healthcare provider is actually a legal definition, and in most states, that definition does not include pharmacist. So what that means when we're talking about implementation here is unless that state statute includes pharmacist in that definition, or unless a statute says otherwise, pharmacists not defined as providers are not guaranteed reimbursement for the provision of clinical services. So, legislation might authorize pharmacists to initiate PrEP, but if it does not address reimbursement, they have no logistical incentive to utilize that authority. So I would just really want to emphasize the issue of reimbursement. Pharmacists need to be paid for their work if we are going to ask them to take on this work. They are already overworked, as I'm sure we have pharmacists here, as y'all can testify. Okay. So this is a map here with states that already have PrEP or PEP specific legislation. Currently, there are 19 states with this type of legislation. I do just want to give the caveat that does not mean that we are seeing perfect implementation in all of these states. It is very much still a work in progress. In addition to the blue states that have this type of legislation, I also wanted to highlight Idaho, Montana, and Iowa that have just general prescriptive authority. So while not specific to PrEP, it essentially serves as PrEP-specific legislation for the purpose of prescribing. Now, I kind of mentioned that we are not seeing perfect implementation in these states, and that is because those nuances are not being perfectly addressed in every state. However, if I had my way, this is what ideal PrEP-specific legislation would look like. Just very brief surface level run through. Would first be direct statutory authority. The reason for that being that this would mean a permanent expansion of pharmacist scope of practice. All of those other 4 legal pathways are essentially just kind of workarounds to give pharmacists blanket prescriptions they can use. This would enable them to be the one writing the prescription. Next up is no quantity or frequency limitations. Pharmacists should be able to keep people on PrEP as well as just starting PrEP. Next up is testing authority. Not only should we make sure that they have the ability to order labs, but also state needs to make sure that they have the ability to conduct CLIA waive test so that they can also offer rapid HIV testing. Again, should not require a standing order from a primary care provider. It should be that direct statutory authority that enables them to be the one writing the prescription. Next up, this legislation should prohibit prior authorization or step therapy requirements, and it should either have minimal or accessible training requirements. Pharmacist-initiated PrEP is something that should be accessible for patients as well as pharmacists as well. Again, if we want them to take on this work, it needs to be something that is feasible to implement into their current scope of work. And then finally, reimbursement clause, emphasizing once again reimbursement. Now, there are numerous different pathways that you can address the issue of reimbursement. The most obvious and the most ideal would be defining pharmacists as a healthcare provider. However, this is going to see a lot of pushback with state legislatures. This has ramifications beyond just pharmacist-initiated PrEP, and a lot of medical associations push back on it because they see it as kind of going into their territory, as you will. So what I offer as an alternative is that there should be a clause in this type of legislation that requires insurers to provide coverage for PrEP and PEP related services at a rate equal to that of a primary care provider. So in practice, what that looks like is that they might not be defined as a healthcare provider, but they would be paid like one, which, again, the most important thing. Now, in the interim of that ideal PrEP-specific legislation, I want to really offer collaborative practice agreements as a viable alternative, which we are going to really dive into further with our wonderful guest here today. But the reason for this is because they can be useful for states either without PrEP-specific legislation or in states with inaccessible PrEP-specific legislation. And what I mean by inaccessible is that pharmacists just might simply find it easier to navigate a collaborative practice agreement than navigate those additional requirements or, again, the issue of reimbursement. So I'm going to briefly run through some states that have implemented this type of legislation. First up is we have Virginia. Virginia utilized the statewide protocol route. They established this in 2021. It does not require a standing order. It covers PrEP and PEP without quantity limitations on both. And something that's, I think, very exciting is that in October of 2024, they actually amended this statewide protocol to also include injectable PrEP. Now, this is very exciting because this is the first state to do so. And while we are not seeing true implementation of that aspect of the statewide protocol, it is significant because legislatures never want to be the first to do anything. So as long as we are starting that conversation of expanding pharmacist scope of practice into that, it is hopefully at least going to get the ball rolling. And then finally, Virginia, again, covers pharmacist services, Medicaid fee-for-service, and managed care, as well as commercial health plans. Now, you don't have to read the fine print here, but this is just a snapshot of what the statewide protocol looks like. And really, the reason I wanted to put it up here is just because, as you can see from the arrows, is it's a very easy step-by-step process for the pharmacist to follow. Again, this should be accessible for pharmacists as well. So it's a very, if this, go to this step. Wonderful. Next up is we have Louisiana. Louisiana passed this type of legislation in 2024 of June last year. This is, again, a statewide protocol. And what's really interesting about this one is that it's actually to be developed by the Louisiana Department of Health. Crazy to ask healthcare experts to be the one, how should we correctly implement healthcare? Wild. But so this, again, does not require a standing order, and it covers both PrEP and PEP. A full course of PEP, however, it does put that 30-day limit on PrEP. So while not ideal, it is still kind of an achievement, also just because it is Louisiana. It's very exciting that we are having this type of legislation down there.
And I want to mention you do have refills on that 30-day supply.
And there we go.
I think it's 3, I don't know if it's 2, maybe it's a 90-day, so that would be 30, 30, 33. 1 and 2 refills.
Beautiful, beautiful. And then Louisiana does require reimbursement at a rate equal to a primary care provider. They took that pay parity route rather than trying to define them as healthcare providers. And it does require additional training. But again, hopefully because it is to be developed by the Louisiana Department of Health, it'll be something that is accessible. Okay. Well, the last example I wanted to give was Oregon. Oregon also did a statewide protocol. This was in 2020. As you can see, it is very similar to Virginia. Virginia most likely did just kind of mirror what Oregon did. If it's not broken, don't fix it. It is still also a very wonderful step-by-step, easy-to-follow process. It covers PrEP and PEP, full course of PEP, 90-day supply of PrEP. Additional training is required, and originally it did not include reimbursement, but in 2021, legislation was passed that does require that pay parity. So finally, I am going to plug some resources for y'all. First up is we have a legislative tracker. This tracks states that have not only successfully passed this type of legislation, but all states' attempts to do so, and outlines the characteristics of those pieces of legislation. I see people taking pictures. And then next up is we have an interactive map. This covers both the authority to initiate PrEP and PEP, as well as each state's laws surrounding collaborative practice agreements generally. This is an interactive map, so you can either narrow down your search based on these predetermined questions, or you can just simply click on your state and it covers all of the laws surrounding the ability for pharmacists to initiate PrEP and PEP. So just to recap for y'all, pharmacists are an extremely accessible option for increasing PrEP uptake. However, if we want them to be able to independently do this, we need legislation passed. And this legislation needs to address training and education, quantity and frequency limitations, insurance requirements, namely reimbursement. But in the interim, collaborative practice agreements are a viable alternative. So on that note, we're going to pass it along. Okay.
I think we can take just a couple minutes. If anybody has any questions they want to ask about those, the first two topics, and then we'll bring our guest up. Yes, I see a hand back here.
So just want to say it's a great presentation. It's not really a question, it's an ask. That when we are talking about PrEP education and talking about the difference between the PrEP modalities, so when we're talking about Descovy, if we could say people born with a vagina instead of female, because that kind of pushes out our trans men. And I think that when we're really talking about, when we say, cisgender men and transgender women, but then we say female. And so we've known all along that trans men have always been excluded from a lot of studies, and now they're starting to be included in studies. And that's just an ask that we use a different language with that we say people born with a vagina.
Thank you for bringing that up. And that's putting it in terms that the average patient understands too. So that's great. Thank you. Any other comments or questions about anything? Yeah.
Comment. I just here's there's a lot of pharmacists and everything in here. When you take the pill every single day, okay, there's a lot of side effects to it. A lot of them are embarrassing side effects. People don't like to talk about them. But more than anything, it's every single day. It's a reminder that I have HIV. Something, there's a problem.
Yeah.
I recently went on Cabenuva, which is the injectable for those that are positive. And I can't tell you how liberating it has been. There's a little bit of side effects, like you said, just right at the very beginning, but they quickly resolve. But not having to take those pills, not being locked into that, and being able to live each day thinking I'm a normal person. That was really key. And I think pharmacists, you're going to be prescribing this. It's really worth it to try to push in that direction, because it really changed things for me.
Okay, great. I'm glad you shared that. It's important to think about the patient perspective in terms of taking the medications and how hard it is to stay on that once-a-day pill schedule, or the liberation of taking an injection. It's good to hear that. So thank you.
Well, and that brings up the new PrEP medication every 6 months.
Right.
So now, if we can do PrEP along with your primary care visit, and we integrate it all into one beautiful visit, theoretically, we can have a lot more prevention.
Exactly.
So we're in an exciting day and age, right? Our medications don't kill us anymore. Our medications don't, they still have side effects, but we're at like the next level. So it's really exciting to be able to have stories such as yours. So thanks for sharing.
Yeah. Yes, in the back.
Yeah, so with pharmacy phase, my question is regarding 340B. How do you guys navigate that?
That's a really good question and something that we've had to take into consideration as well. For example, if you're prescribing medication under a collaborative practice agreement, a lot of times you're signing the physician's name that signed the collaborative practice agreement, who's a provider at the clinic. And so you can use that as your method of qualifying the prescription as a 340B prescription. Otherwise, you can be listed as a provider, but there are of course challenges of being listed as a provider. But that's a really good question. And a lot of times, if we can't qualify, if they don't, and we can navigate some of those challenges initially and refer them back to the clinic to see a provider. Yeah.
Follow-up question with that. So I'm not sure, but some of the states require you to have to be Ryan White funded in order to be 340B. You guys know anything?
That's one leg of eligibility. So you could be a Ryan White provider. You could have an STD grant as a sub-recipient, HRSA, or you could be a federally qualified health center. So those are the three ways to access the 340B program.
Good question. Thank you. Any other questions? Yeah.
In any of these that have been implemented, have you looked at like retention and care or like discontinuation rates, and perhaps like compared those to traditional methods of prescribing?
There are studies that have looked at that, that say it's been overall very successful in terms of retaining patients, again, because you're very accessible to the patient. And so there have been, we haven't personally looked at that. It's something that I hope to look at in the future for our programs. So yeah. Yep.
I just wanted to mention that when we started offering injectable PrEP, we had more women partake in the PrEP program than again when we just had oral PrEP. So we've been really focusing on trying to get Black women and on PrEP in our area. And I'm in Baton Rouge, Louisiana, Fast Track City, and that has really helped us. Okay. And I think that might be because they used to get an injection. Depo-provera is very common form of contraception, and so it's been more acceptable to them than the oral.
It also lets them not have the bottle at home.
Yeah.
They're not gonna see the bottle.
Nobody sees it. Okay.
Yeah.
Nobody sees it. Yeah.
Yeah.
Good point. Any other comments or questions before we move on to bring in our guest up here? So if you guys will go ahead and come up. I want them to share a little bit about how their programs are structured. And so we'll ask some questions, but I want you guys to feel free to jump in and ask questions as we're talking as well. Do you guys want the microphone? Sure. Let me sit. Okay. So I'll start with you. Can you tell us a little bit more about how your program is structured at Raphael Health Center?
Yeah. So like I said at the beginning, I run our PrEP program at Raphael Health Center. So within the structure of it, I coordinate the program. I have a PrEP navigator, and then we're going to be partnering with Alchemy to do some mobile unit testing, just to kind of bring access into the community.
Okay. And what were your motivations to start your program to begin with?
So part of our initiative is at the Raphael Health Center, where we're located at in the city, we target 3 specific zip codes. And within those zip codes, we do have a fairly high rate of STI. So that is the motivation we have a lot of significant barriers that are preventing people from being able to access pharmacies, to being able to access healthcare. So this is a way to reach the community where they are and meet everybody where they are, so that way they can get this essential medication.
Okay. In terms of how your mobile unit is structured, you mentioned you have a pharmacist, you have a PrEP navigator. Can you talk a little bit about staffing overall, services that you offer? Are you doing any testing outside of having a mobile unit, and how all of that works?
So as of right now, what we've been doing is trying to collaborate with the community so we have some partnerships with a couple of recovery homes, with food banks, and then also with some homeless services in the city to kind of do some outreach initiatives. So we provide free HIV and hepatitis C testing. We offer some education services, and then we help link to care so we can get that initial treatment started for patients, and then also connect them to our to our health center for that primary care, so that way they can deal with any sort of health issues.
Okay. Along with talking about the motivations, being a PCMH coordinator, motivations might be slightly different, or I didn't know if you wanted to make some comments as well about the motivations behind Raphael.
I think for us, it's also we've always strived to help anybody and everybody in the community and be all inclusive. So, like Abby said, we do have a high area of need for like STI high risk and 46205, 208, and 46218. But we also don't limit our services to those zip codes. We'll expand anywhere within Marion County. Marion County is about 400 square miles. I think that on a good day with no traffic, you could probably get from end to end in Indianapolis in 30, 40 minutes. But we do some other things. So like I think a lot of the presenters here that I've heard today will go to the community because that's where it's at. That's where the need is. So we have done some other things where we go to laundromats. That little picture at the bottom there, that's our mobile unit. Our newer, like we only have one, but that's a barbershop. It's a Dominican barbershop. We get like 30 men there. We tested, I think, 5 or 6 last Saturday. So we also try to be just really innovative and creative and try to target, again, everyone. One of the things is that, we do try to target MSM and because there's a high risk and that kind of stuff. But then I always tell the team too, it's like, we can't forget the women. We gotta do something with women as well. So I challenge them to be creative and innovative. So we have done some churches as well. Susie introduced us to a local food pantry. So yeah, we're trying, and then we also try to be at spots where nobody else is testing because our PCHIP program is fairly new. We started like in the end of 2023, and we're kind of late into the game in Marion County because like our local health department's well established with STI testing. There's other local agencies that do a lot of testing, so we do collaborate with them, but we also want to play in the same sandbox with them, but also do kind of our own thing and spread our services.
Okay. I guess a question for either one of you. You mentioned that patients face challenges and barriers sometimes, and I'm curious how you address those, how you identify those, and how you help patients overcome those and link them to care.
Okay. So one of the other programs that I run at the Raphael Health Center, I am in charge of our community health workers as well. So one of the things that we do is we're always assessing, what is preventing you from either accessing medication or accessing medical care. So we do offer some services to help patients with transportation because transportation is a huge barrier to care. And then just try to help them figure out, you can't worry about medication if you don't have a place to sleep. So it is very vital within my team that we're trying to link people to care, whether that's at the Raphael Health Center, whether that's to other community agencies. Care is care, and people can't access their the essentials that they need if they don't have a place to sleep. So, I mean, like, we try to do a full like wrap around so that way we're able to help the patient where they are.
I would also add that where we're located in Indianapolis, we're also like in a food desert. We're also in a pharmacy desert. So the closest pharmacy to the clinic is probably I don't know, 3-4 miles down the road, maybe. So because of that, we've also partnered with Alchemy to build an in-house pharmacy within our clinic. So now our patients have access to the medication. Like, they see the doctor, they can go over there, get their script, and then they can go about their day. So because a lot of the pharmacies around us, the CVS and the Walgreens, some of them are closing. So that's really limiting access to medications.
Okay. Have you had any challenges that have come up as you've worked toward implementation of your program? And if so, what have those challenges been?
I think some of our challenges are one of the things that when we when we first started the program, to be open and inclusive to everybody, is that Raphael Health Center is like our parent company. That's the go-to. So you look at our logo, it's a cross. When we're working with, just LGBTQ community, that kind of stuff, the cross really threw a lot of people because they're like, I'm not going to be judged. We are a faith-based center, but we're non-denominational. So basically what we do, if you come to our facility, you go to your doctor visit. If you want to pray with the provider, you can. It's not mandatory, that kind of thing. But the cross always throws everybody off. So one of the things that we did is we rebranded our program to Our Lives Indy. And if you go to ourlivesindy.org, you'll see our website. We had that customized done with color, like different, just nice colors and different pictures, variety and that kind of stuff. So I think that's one of the things that was one of the barriers. And also too, just kind of, we know what we know. So we launched the program. We're flying. We're building the plane as we fly, and we're learning as we go. I don't think there has been too many hiccups. I think there's sometimes a delay with actually building the mobile unit. That took about 4 to 6 months. We had that customized out in Denver, Colorado. They took it in January and they just returned it in June. But it's more logistic things. So that kind of things. Right. Yeah, those are the things that you probably need to plan for when you're trying to look at this, like, trying to do a mobile unit, that kind of thing.
Okay. Knowing a little bit about Raphael Health Center, and I'm going off script here, so be prepared. But I was wondering, knowing that there haven't been clinical pharmacists practicing in Raphael, at least that I know of, has there been any resistance from medical providers to this type of model that you know of, or?
No, I don't think there's any resistance. I think for us is having our providers prescribed to the pharmacist. That was kind of like one of our even just pain points when we started up just the internal pharmacy, because they were still sending things out to Walgreens and CVS. I mean, that's not mandatory if a patient wants their medication to go out to one of those pharmacies, and we do that. But it's just like, hey, we have this resource here. Let's try to get this, let's try to use the resource. So I think that's the biggest, and it was an educational thing for the providers. But you wouldn't think that would be an issue, because it's like, here's the, patients, or go to the exam room, the pharmacist right here. It's like right there. So we had to kind of educate providers on, like, use the pharmacy. So I think it was more of an educational thing versus like pushback or anything like
that. Good. Have a question about how you're tracking your patients and the difficulties that you might have in tracking patients, from testing to actually following up in the clinic to receiving care if somebody tests positive. I know there's definitely challenges that come up with that, and so just curious what challenges you've experienced.
So that is definitely a concern. Because of some of the areas where we do testing, somebody may not actually have access to phones. Mm-hmm. So by the time that we have everything in place, like with their test results or even getting them in the clinic, there's no guarantee that we'll be able to get in contact with them. So that is where our PrEP navigator really comes in to kind of work with the patient, establish that rapport, figure out a game plan. You don't have a phone. How can we get in contact with you? Or how can you get in contact with me? So then that way we're able to make that connection and keep in contact.
Okay. I guess one final question before we move on and ask you questions. Do you have any advice that you would share as a program that's further along than maybe some programs that are in the room in terms of how you launch a program? Either one of you.
I don't know, Fernando, do you? I think give yourself plenty of time. It's very time consuming. It is not something that gets up and running in a month or two. There's always delays. Even when you have funding to get it off the ground, there's going to be delays.
Mm-hmm.
Yeah, I would think I would agree with that. The biggest thing is allow yourself time. In our instance, we've been, I guess, blessed and fortunate that money really hasn't been an issue. Matter of fact, we've struggled to spend some of the money because there are ways you have to spend this grant money. But time,
Awesome.
It's a good problem to have. Yes.
time is everything. You have to be patient. I think in Indiana, one of the other things is too is like we would really like to have a provider that's focused on HIV treatment and prevention. We don't have one that really does that kind of work. But it's hard to find one because like we have to compete with salaries of big hospitals and that kind of stuff, and that's really challenging for us. So finding staff sometimes is challenging for us. But I think time for us, and then finding a provider, because we really struggled to find a provider just to do care for our program.
Okay. So Leanna, your program at the center is structured a little bit differently.
Yes.
And so if you would just take a few minutes and comment on how your program is structured and I guess
Absolutely.
the motivation behind it.
Yeah. So when I graduated pharmacy school back in 2000, I was like, okay, what's the first thing that I could do, right? And the first thing that I could do was become HIV certified. So I went out and I started working those scripts so that I could meet the 50 patients a year for 2 years. I took the exam, all of that. So that's kind of where like my passion for HIV and PrEP and PEP all kind of stemmed from. So, sorry, I'll talk into the mic. So, with that, being in Nevada, we're like the wild, wild west, right? There's a lot of stuff that we need help with, that we're lacking with, that we need innovation and innovative people to do. So I heard of this amazing thing that was called a collaborative practice agreement. At the pharmacy that I was working at the time, I worked with some of my HIV providers and did this collaborative practice agreement for PrEP. It was not easy. It was a pain in the butt. I was not supported by the company. They don't give you time to see patients when you're a pharmacist. I was not supported with reimbursement because I'm basically seeing this and doing this for free and not filling the 5 million prescriptions that they wanted us to fill. But still, it was something that filled my soul, right? So as we progressed, like I know the value of a pharmacist. I know the value of making that connection with those patients. And guess what? When they see you and get that prescription from you and you get to talk about all of this, damn right they're going to come back, right? Mm-hmm. Like they come back to you and the adherence is higher. And now it's just such a valuable aspect that that I really want to carry on at the center that we have here. So we do have 2 clinics. We have an STI clinic and we have a primary healthcare clinic. And I like to tell the story, right, about pharmacists and pharmacist accessibility because it was a Friday afternoon. Because, that stuff always happens on a Friday afternoon, right? Unless you have plans during the week, and then it happens on that day. And I pull up, and I'm getting ready to go. I have my car. I'm loading my stuff in the car. And this woman comes up with her 2 kids. And she asked me, do you work here? I'm like, yes. How can I help you? And she's like, I need to talk to somebody. I need something happen. I need to talk to somebody. And I'm like, okay, like medical, right, program? And she's like, no. She's like, I had sex with someone. And her 2 kids are older kids and they're standing right there. And I could see like her like embarrassment and her shame. And so I'm like, all right, sure. I close the trunk of my car. I bring her in to the clinic, right? I have the kids go sit down and get magazines and stuff and keep them entertained. And I'm taking care of this woman. And not a lot of places can do that. But I think we as pharmacists, we have the capacity to be able to do that. We have the keys to the pharmacy. We have the keys to get in there. We have, the medications and the ability to fill it and the access to all of that. So when we talk about pharmacist-led PrEP, those are the stories that I think of. Those are the situations that I go back to. It's the people that we help, the connections that we make, and the way that we're going to be able to sustain the future, right? We have all kinds of crazy things. Lucky, Raphael has money. We don't, right? So we have to think of these out of the box ideas of how we can fill these healthcare needs. How can we fill these healthcare voids? And this is absolutely one of the ways that we can. So totally took you off on a tangent, probably not what you were looking for, but
No, that's perfect. That's perfect. Thank you for sharing that. I guess, how is your program structured within the pharmacy? Taking into consideration we're doing it from the pharmacy counter.
So doing it from a pharmacy experience where you're not really supported, and doing it from the clinical experience where we're at now, two very different pathways.
Mm-hmm.
So struggling to get that Quest lab bill and appointment and all of that, and struggling to get the patient in to get their labs. And whereas now pharmacists have access to our EHR system. They can order labs, boop, 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 right? It's so much easier and it's such a better process. So it is a shared EHR system. So if the pharmacist is out, my cool Emily can take over, right? And look at the labs for us, who's one of our providers. And you have a much more robust team versus when I first started doing it.
Okay. And I think along with that, in terms of the lab work, the STI testing, how do you manage all of that from the pharmacy?
It's fairly easy because it all pops into the EHR. So we're able to assign the patients to the pharmacist. The pharmacist can go in, log in, see all the labs that come up, see what the patient's profile looks like, when were they last in. We also have, I'm so lucky to have, we have a PrEP navigator. We have amazing people who help with prior authorizations. I have amazing providers that support us 100% through everything. So when we build that community together, it makes everything so much easier.
Okay. How do you plan to manage stigma and patient privacy and HIPAA concerns, I guess, from pharmacists prescribing from the counter?
So, we're the center, the LGBT center, right, of Nevada. So we've always managed stigma. We've always dealt with how we're perceived in the community. So we have really excellent people that we talk to people. We bring them in as they are, who they want to be. Like, we're very invested in our community and in the people that we serve. And usually it's just a conversation,
Mm-hmm.
right? Like, if we have our population, our people who are in front of us, if we have them involved and engaged in that, our own healthcare, it makes everything just so much better and so much easier.
In terms of billing challenges, have you had any issues?
Oh, good Lord, yes. So billing is probably one of the biggest challenges. So we do have a law now in Nevada that pharmacists can prescribe PrEP and PEP. And it's fairly vague. It says PEP and PrEP. It doesn't specify what drug, what medication, or how many or how much. It does say that we should be able to get reimbursed, but we don't, and we're not. We have to go through a training, which is, pretty standard. It's a pretty good training that they've developed. But trying to get credentialed with the insurance, there's one stopgap after the other. So that's why it's not been picked up in Nevada as much as we would want to, right? Like, we have pharmacies on almost every corner, but very few pharmacies and pharmacists are actually doing this and engaged in the program.
Good. Thank you.
So we're open to any help, suggestions.
Yeah.
See me after.
Which is a good segue into what I was going to ask next. Does anybody in here want to share a little bit more about their programs? If you have a current existing program, how you're structured. I remember people in this general area, maybe. Was anybody in this area have a program already set up? No? I see a hand at the back. Yeah.
Yeah, we actually work for Health Force of Ohio. We're FQHC in Southwest Ohio. So we actually work under a collaborative practice agreement. So Ohio does have providers' rights for pharmacists. However, Medicare does not recognize that, and a lot of third parties don't. But our state Medicaids do. So we get around the billing by doing incident to billing through our providers. So we're actually in clinic with nurse practitioners, MDs, ZOs, but we also have in-house pharmacies that are directly connected, like from a door, so we have then the retail side of pharmacy. So we are the clinical pharmacist. So we're in the clinic, and then we can actually prescribe PrEP, manage PrEP. In fact, none of our other providers do that. So we are the clinical pharmacy team runs all of the PrEP for HIV, and we also do Hep C clinic. So we do have like a physician champion that if we have questions or we need like collaboration, we can always reach out to them. But it's mostly 100% run by clinical pharmacists. So we do all of that. We run the labs. We do everything like a nurse practitioner or DO would do, and how they are a provider in that sense. And then we walk them right over to the pharmacy, and we actually have a prior authorization team, which is new. We just started that last year, and they're actually certified pharmacy technicians who are the PA team. And so they are able to instantly go in. We've had really great success. Less barriers with HIV PrEP with PAs in Ohio, at least. Aptitude is probably one of, since it's newer, we're having a little bit more barriers. But still, it's been very successful. We do the Aptitude injections right there in the clinic. So it's great because Ohio Medicaid has Aptitude as no PA, and so our pharmacy can order it, we can bring it over, inject, and do all that. We also have an in-house lab, so we're pretty grateful for our setup.
Full package, right? Self-sustaining, 100%.
Yeah, it definitely is. So it's a very nice, I think, program that we have. It is a newer program. So originally our collaborative practice agreement was chronic diseases like diabetes, hypertension, and then we were 6 months into that, and then our CEO was like, hey, how about Hep C and HIV PrEP? And so it's nice having leadership coming and saying, hey, pharmacists are valuable and they help with adherence. So we've developed, Hep C and HIV education materials for our patients, so they leave with resources. Because that's a huge piece, at least for pharmacists, that we love is educating patients. And we want them to feel equipped with knowledge when they leave. So they feel comfortable being adherent to medications. If they have side effects, reaching out to us and letting us know about that. So that's a little snapshot of our program.
Can I ask a question? So you said that it's clinic-based. Is it appointment only or is it walk-in as well?
Yeah, so for clinical pharmacy,
Yeah.
It is an appointment only.
Okay.
Yeah.
How far out are you guys scheduling?
Oh, we have a great turnaround. Yeah, so very soon you can get in.
Both for you and these guys as well, have there been any challenges with or patients maybe surprised by the fact that they're interacting with a pharmacist and not a provider when it comes to prescribing PrEP? And if so, how are you addressing those challenges as they come up?
Yes, a little. I wouldn't say as much because a lot of times they're coming from a provider already. And so their nurse practitioner, their DO has already said, hey, I want to send you to clinical pharmacy. They're going to do education. So there's already been that kind of warm hand up. But every now and then you have patients who miss that part of the discussion. But we've not received, you can probably speak on that as well. Have you had any pushback on that?
I haven't. Probably the most that patients want to know is just, is my primary care provider aware of what's going on? So just making sure that they understand the collaboration that again, with the way we chart, for example, we do send a copy to their primary care provider, so making sure that they're aware, the patient is aware that primary care is fully engaged and that we are a team in providing this care to them.
And how do patients know to schedule appointments with you if it's their first encounter for PrEP? Are they referred from a provider, another provider, or how do they connect, I guess, with the pharmacist
Yeah,
clinic?
that's a great question. So we do internal referrals, which is so we have 21 health centers, so that's OBGYN, dental, we have all kinds of different providers, and they can refer. However, we've now incorporated outside referrals. So we've partnered with rehab clinics, that do match as well, and so they can refer in. We've even worked with our local health departments at their syringe exchanges, and we've actually had referrals from them come in, which has been super rewarding for us because now we can establish care not only for HIV PrEP or even Hep C, but also primary care as well, because these patients typically don't have a primary care provider.
Mm-hmm. Yep, absolutely true. Anybody else want to share anything about a model that they are working under? Yeah.
Can I share about a question?
Sure.
As we've mentioned aptitude, and obviously as to those new to market, how do you all see, maybe specifically for the center, like how do you see the role of pharmacists prescribed PrEP evolving as injectables become more and more common?
I hope that our future, that they take a lot of the load off of the clinic, right, and allow our providers to do a lot more of the primary care. So we already do a lot of the aptitude. We do a lot of the injectables. We administer injectables, right, all of that. With what we're working through now with the 6-month indication is how do we educate our patients that they still need to come in and get the STI testing. Right? You may have heard earlier where my goal is, I'm like, let's get everybody every 6 months, yay, right? Now we can integrate it into their primary care visit every 6 months, yay. But it's all about that education piece too, and making sure that they know and understand, right? This isn't the end all and be all. We still need to see you for syphilis and gonorrhea and all of those other things. But I love being a pharmacist. And I love to empower my pharmacists to do more and do great things, right? It's fun. Doing this stuff is fun for us. So again, I would love to have them continue their role in the injectable landscape as it comes. Yeah, thanks for the question.
Anybody else have any questions to ask? Yes.
So I know that there are programs from the drug manufacturers to help with education or with patient support that clinics would use. I was wondering, are pharmacists also taking advantage of those? And is there a way that, or any way that you think that pharma can or should be more engaged with pharmacists?
So I'm always very engaged. I really enjoy talking to pharma. I enjoy the information they come, and I use I use one to talk about the other's downfalls. I use the other to talk about this, and then I get to all the information of everything, right? I love as many resources as possible. Like if you sit down and quack at me, I'm not going to retain it, right? But if you show me a movie, absolutely. Or if I hear it 2 or 3 times, then it's a little bit better. So I love multimodality. I love, any kind of resources that we have. And I mean, uninsured patients, we can still make sure they get their meds. And that's an amazing thing. We can do rapid start. We can do samples. We can do, we work with pharma closely to making sure that these medications can still be in the hands of the patients.
If I can maybe actually ask a follow-up question.
Yeah.
Is there anything manufacturers can do to better tailor the support that they're providing their clinic for pharmacists specifically? Because I know a lot of the time it's pretty provider agnostic. So is there anything more specifically that they can do to support pharmacists?
That's a great question. I think a lot of times pharmacists may be overlooked. I think if you are in the HIV community and they know you, they will, they'll visit you and give you education. But I do think there's a whole world of pharmacy and pharmacists that don't get any of education and don't get any access to any of this and don't even know, right, that you can get a free month of medication by going in this program and yada, yada, yada. So I think, there is a definite miss on knowing what resources are out there and available.
Yeah, I think along with that, with patient assistance programs in general, but yeah, the ability or even knowing where to go to apply for those things, like you mentioned, is a big challenge.
Like, I never want patients to walk away without meds, right? So like my goal is to do every single thing in my power to make sure that they get the medication that was prescribed that day by their doctor. And I would love that to be emulated through all of pharmacy. Yeah.
Mm-hmm.
I think for us at the clinic too, like we use MedData, so that's kind of like a library of all the drugs and how you can get the discounts, and it helps you track the progress and where the authorization is. That's been really helpful. We're going to introduce that to our pharmacists so they can have access to help them out. In FQHC world, so the climate changes every day because of the political stuff. So that's where like sometimes that's why I said sometimes we have excess funds because we have the money now we don't, and so it goes back and forth. But so for that we also try to prepare. So we also like try to implement like dispensary of hope and that kind of stuff to get different meds in case Medicaid is cut or something like that. We're going to have more uninsured patients and that kind of stuff. So we also try to plan and prepare for that kind of stuff by adding those additional resources.
Speaking of that, I was actually going to ask you a question about that because I know that you all have been very intentional in partnering or working with charitable pharmacy programs like Dispensary of Hope. And just wondering if you would share just a little bit more about, I guess, how we're setting up those programs. What is the interest for the clinic in setting up those programs, and are there any challenges?
Yes, I think the interest of the clinic is so that everybody has access to meds, especially if people were to come, if we experience more uninsured, people lose coverage, Medicaid, that kind of stuff. So I think that's the one of the main interests, and also too for like our undocumented population. I don't like to use the word undocumented, but to help with those kind of resources, because again, the world that we're in, we get rules or executive orders that says like, you can't help anybody who's undocumented and that kind of stuff. So it's also to prepare for that kind of stuff. So we try to be really proactive. Again, the goal is just to make sure that everybody has access to their medications and they can go home and be healthy and control their diabetes or whatever they have,
Yep.
And it's a new path for us too, because like we're also incorporating that kind of stuff into our sliding fee scale and that kind of stuff. So it's a huge undertaking. That's a lot of work. So yeah.
Okay, thank you for sharing that. Any other questions from the audience? Yes.
Do either of your two clinics work a PrEP program or have a PrEP group?
Yes. So we have our STI clinic it's a appointment and walk-in based clinic. Our goal is to get patients their medication that day that they come in, which the walk-in is super important. I want to make sure we always can maintain that and keep that available to the community. But yes, we do PrEP. We almost always have a provider on site, whether it be doctor, nurse practitioner, pharmacist, etc. But if there's no one on site, our team does have access to call a provider, and we can do an urgent telehealth appointment right then and there. We also, if we have our pharmacy on site, but if for some reason the pharmacy is closed, we have samples. So there's literally zero barriers to getting these patients on medication right then and there. Yeah.
And what about you all? How do you manage patients that need PrEP?
Well, we currently don't do PrEP, but with our CPA that we're going to do with Alchemy, Susie's actually going to be our pharmacist that's going to be on our clinic or on our mobile unit and that kind of stuff. So the goal is to do PrEP with her. We don't do that. We have purchased all the resources and the technology for the mobile unit. We have purchased, I think, some extra Apertude injections, right? So we can kind of start that, and that way there's no barrier to starting Apertude and stuff like that. If somebody wants to start the same day, we've bought the Piccolo machine. We're not endorsing Piccolo like Susie said. And then we've also started, we bought the rapid Hep C machine, correct?
Yeah.
So we're ready to do point of care testing. Abby and our PrEP navigator, they're going to go through phlebotomy testing and that kind of stuff. So once they do all that, we're going to have hopefully the full package and be able to roll and do a lot more services.
Yes. Any other questions from anyone?
We're like, it's 6 o'clock.
I know. We might
Last
finish a little bit early.
session.
Okay. Thank you all.